movie called The Longest Minute. Things I think about during this minute. Oh, it's 12:35. It didn't last that long this time. I must have cut it at the end. All right. Well, welcome, everybody. This is the Clinical Consultation Network. We do this every Tuesday at 12:30. So glad you can join us today. We have a wonderful guest in Kim Rush King, who is with NAMI, and she is going to talk to us about mental health and IDD, which is a subject very near and dear to all of our hearts. So thankful that she could be here today to talk to us about this. We'll get into all that in just a moment. Let me make a couple of announcements first. So upcoming on CCN, we've got this presentation today on May the 2nd. Then on May 9th, we have a case presentation. This should be an interesting discussion about a case that we have in the community where someone is having some difficulty, and we're just going to try to brainstorm through that case, access the network's knowledge and information so that we can help this person with this case that they're dealing with. May 16th, we've got 10 Start, Mental Health with Michelle Bagby. This is such an important program that we're offering now through the Department of Intellectual and Developmental Disabilities, and Michelle is going to be here to talk about some of the outcomes and some of the things that we're still working on with respect to 10 Start. And then on May 23rd, we've got our NAD collaboration, that fourth Tuesday feature with NAD with Dr. Brandy Kelly. Dr. Kelly is quite an interesting person, and she is going to be here on May 23rd to talk to us about her work. And then on May 20th, we have the Tennessee Association for Mental Health Organizations and Volunteer Behavioral Health talking about 988, the new suicide hotline that we have out there. So this is a great lineup that we have upcoming. And then today we have as our guest Kim Rush King. She's currently employed with the National Association of the Mentally Ill, and she is the statewide CIT director, crisis intervention team director, as well as project director for a federally funded grant by DOJ, Department of Justice, which focuses on an 8-county region and helping develop and implement CIT. Furthermore, she's working with departments outside of the 8 counties with the purpose of developing their CIT team for the county and establishing partnerships with community agencies and law enforcement. So please welcome today Kim Rush King, who is a great partner. So glad she could come on today and present to us and give us all the information related to CIT and all the stuff she's been working on. Kim, welcome to the Clinical Consultation Network.
Thank you so much, Dr. Davis. I really appreciate it, and I appreciate being invited to this. So thank you for allowing me to be here. I am the statewide CIT director, but, you know, my background really is mental health. I've worked in mental health for over 30 plus years, which is a long time when you really start thinking about it.
Yeah, you know, it feels like a long time. I've been in the field of IDD and mental health for 35 years. In one way, it does seem like a long time. In another way, it feels like it went by in a wisp. You know, I don't know. It's both feelings I have about it.
It does. It does, and I completely agree with you. You know, when talking about mental health and the IDD population, and then having been blessed to have been a part of mental health for so many years, I've seen so many changes over the years. I can remember when I was in undergrad and then graduate and then postgraduate, and not any of those ever talked about the relationship between mental health and the IDD population, which is what's fascinating to me nowadays. And so that's why this subject was really interesting to me, because I never had any training. I was blessed with my undergrad college that I went to here in Tennessee. They actually had a dually diagnosed program on campus. It was a day treatment for IDD and mental health. That was my learning ground.
Where was that? Okay.
I actually graduated my undergrad degree from Tennessee Wesleyan in Athens, Tennessee.
Okay.
And we had a day treatment program, and it was designed for folks that had a dual diagnosis of the mental health and the IDD.
Wow.
And
Hey,
so I got definitely hands-on training, no doubt whatsoever. But as far as being formally or classically trained, no, there really never was
yeah,
any.
there aren't that many programs out there that do that, and I'm part of the National Association for Dual Diagnosis. I'm actually the president currently, but it's that's where I've probably gotten most of my exposure to
Mhm.
training with respect to IDD and mental health. And so, but it's scarce out there, and certainly at the university level, not nearly enough resources to address
Absolutely.
the issue the way it needs to be addressed.
Well, and I have found that, again, being very blessed and fortunate to work in community outpatient settings for as many years as I have, and was the director of several outpatient clinics, we would have someone with an IDD come in, but that didn't seem the primary focus. So what I saw, in kind of looking back on in dealing with kind of bridging that gap and creating this bridge for mental health and IDD to come together, because we know it exists. We know that several of our folks with IDD has a mental health disorder as well. But I
Yeah,
think what we're going to have to do is there's going to have to be some better training going on. But some of the barriers I see when dealing with that population is the fact that there is no training. So a lot of therapists don't really know how to deal with somebody that is with that diagnosis and then diagnosing them with clinical depression. So
yeah,
therapists, I think, had a tendency to treat more the clinical depression and not the combination of the two. I liken it to what we have done and what we've seen, the growth in co-occurring. Years and
right.
years and years ago, alcohol, drug did not mix with mental health.
It
And
mixed
you were
with it,
either
just
in
not in therapy, not in the therapy session.
exactly,
So,
exactly.
uh,
But you were either
people,
part of that substance use world or you were a mental health person. And they never did meet until we finally started doing more research and recognized that the two kind of go hand in hand a lot of times. And so
yeah,
now that's why you see co-occurring enhanced programs. That's what I'd love to see when it comes to the dually diagnosed, is recognizing that they are coexisting with each other. But I think training needs to be one of our first steps in bridging that gap between the two. And I appreciate the clinical network, and I appreciate how vocal IDD is, because we need to educate people.
well, yeah, I appreciate that, and we are trying to help people understand. I talk about 35 years. I feel like this has been the drum I've been banging for all that time. It's
Right.
basically to help people understand. Yes, you may have intellectual and developmental disabilities, but that doesn't explain everything. And sometimes, first of all, neither is the mental health disorder that the person may have, because there are lots of other things about people's lives beyond just their mental condition, but the type of life that they're living and the quality
Right.
of their life. That sort of thing is a huge factor. But it is important, if you're going to have a quality life, to be able to meet those basic health standards that we have.
Right.
That it's sort of like Maslow's hierarchy. We got to get our safety and security met, and that's basic health and mental health is a part of that.
Right.
So that's why I think NAD and me and you all fight so hard to help people understand this enormous need that people with IDD have.
Well, what's also interesting to me, when somebody maybe is dually diagnosed, a possibility of being dually diagnosed, that type of treatment diagnosis comes in the mental health setting. So it's a community outpatient center that the person may be attending, which is really not conducive to the IDD. And so not only is training a barrier, I think, when trying to create this bridge between the two, but I also believe that because it's in the mental health setting, we haven't done anything from mental health or much of anything to kind of have a setting that IDD would feel comfortable in.
Right.
And so I think that's something else that we need to do when working with both groups, or just being dually diagnosed itself.
Yeah, I couldn't agree more with you there. And I was talking about the START program just a little earlier. The START program has been great. I know you've had a lot of interface with Michelle and the whole program, and it really is a great piece of the puzzle with respect to this. And I think it covers a large proportion of the variance in all of this. There's that small set of circumstances that we face periodically where a person really does need to get to another place to get some intensive treatment for a period. But our goal is always to get people back to their community setting as quickly as we can, as efficiently as we can, because that's where life is lived, not in the halls of an institution or a hospital. And so, that's one of our greatest deficits at this point, is being able to get people where they need to be at those rare times. I don't want to say overly rare, maybe about 20% of the calls we get, we think the person may end up needing to be hospitalized for a period and then return to their community setting.
Right. Well, and
I don't know, do you have a presentation you're going to do today, or I don't want to continue questioning you and everything if you're going to do a presentation, so just guide me a little bit.
I prefer just talking.
Okay, well, we can continue
and
on
just
that
talking
basis.
and asking questions and getting feedback from everybody, because I think that's the way that we really learn. Because my guess is the majority of people on this already understand that there is a deficit there when it's comes to treating dually diagnosed folks. I mean, working in the hospital setting, I worked at the state mental health hospital here in Nashville, and I remember them telling me that one group that they're just uncomfortable with accepting is somebody with IDD.
Yeah.
Even though they were most appropriate to be admitted. And again, it just goes back to lack of education and training.
Yeah. Yeah. And of course, that's something we really have to work on, is getting these facilities to make the reasonable accommodations they need to make to be able to do this. And I think they are generally very reasonable. And it's inappropriate to paint people with IDD with a broad brush and say, oh, well, we can't do this. It's just a matter of digging in and wanting to learn what you need to do to be able to do it, I think. And so this is such a critical thing. One of the things I was going to ask you about, Kim, is your experience with CITs out there. These crisis intervention teams that exist within some police departments. Maybe even talking a little bit about the history of the one we have in Memphis, just so people understand that a little bit, but also how that spread across the state and the work that you're doing in that regard.
Well, as far as CIT is the crisis intervention team. It is a Tennessee model. It's called the Memphis model because it started in Memphis, and it was in response to the Memphis Police Department had been engaged on 2 or 3 different calls with folks who had a significant mental health disorder and diagnoses. And 1 or 2 of them had already just been recently diagnosed from Memphis Mental Health Institute, the state institute. And unfortunately, 2 or 3 of them, well, 3 for sure, ended up in the death of the suspect. And NAMI has different chapters or affiliates across the state for counties. And so in Shelby County, the affiliate there went to the Memphis Police Department. And instead of being so, outrageous and aggressive with
Kim? We didn't lose you, did we? Uh-oh. She may be having a little bit of a technical problem at the moment, but while she is correcting the technical problem, and while Babs is maybe helping her do that, I hope, then we will. I just want to encourage everybody out there, if you have questions or comments about this to help with that, come on and make give your questions or comments. Of course, Kim and I have known one another for a little while, so are you back, Kim?
Yes.
Okay, great. I was just encouraging. You may have to stay off camera to keep your bandwidth good there. But I was just encouraging everybody in our audience today to come on and ask a question or to make a comment if they wish to. So this is an open forum today that we will use for the rest of the hour. But anyway, you were in the process of explaining your experience with CIT.
Yeah, and so CIT started in 1988 due to some issues that had happened between Memphis Police Department and those diagnosed with a mental illness, which never really ended well. And so everybody got together, NAMI advocacy group there in Memphis. They got together, and Major Sam Cochran and Dr. Randy DuPont with UOM, they basically created this CIT program, and it brings community partners together. And so when we, one aspect of CIT is that we also provide training to first responders. We have trained law enforcement, dispatchers, fire, EMS. We are now in the process of training park rangers. And I've also had several of the schools and colleges within the Davidson County area that have reached out because now they want CIT training for all of their campus police because of what they deal with from a mental health perspective on a daily basis. And so we provide education on different mental health topics, but one topic we always include is IDD.
I was going to ask you about that. So you include that in your training?
Absolutely.
What types of things are you talking about in that training for CIT officers?
Well, as far as with the IDD, we're very fortunate to have had Michelle come and actually present. And I know that Babs is going to be presenting at our Montgomery County CIT training next week. And so it's kind of giving them an education. There's so much stuff, and we know that, but kind of educating them on what is considered IDD.
Yeah.
You know, something as basic as that.
Yeah.
And I have a tendency to believe that during those trainings, they do get a lot of talks or questions regarding autism, because it's not unusual for our law enforcement, EMS, first responders to come in contact with somebody who may be diagnosed with autism. However, they may be diagnosed with the mental health as well.
Correct.
So it's kind of going through those topics, each one. Michelle would talk a little bit about each one, maybe under IDD, and she explains that this could be a day, week-long training just in IDD, because there's so much to learn and so much to know. But I have found that it really does provide them some good knowledge. And to me, if the more you know, the better off you're going to be. And so they're going to be able to recognize that somebody they may have the mental health, but the IDD as well. Because, in mental health, we never diagnosed IDD.
Right.
We used to have the 5 axes and the DSM, which we don't have that anymore. But the second axes, that really was where IDD diagnosis would go. But we would depend on outside people to give us that information.
Right. Yeah, I think a lot of people rely on mental health professionals to provide the other side of it as well. Of course, we end up sometimes, I don't know if you've ever seen this, but we end up with people who have laundry lists of diagnoses. And it becomes difficult at some point to sort all of this out.
Right.
I wonder have you seen that phenomenon?
Absolutely, because the reality is so many times we have folks that are misdiagnosed because they may be presenting in one particular way that day. And based on the symptoms that day, it could be, well, there's clinical depression. But then they start exhibiting some of the other symptoms of maybe a bipolar. So all of a sudden, they've got a diagnosis of clinical depression, of bipolar disorder, and then maybe the IDD, and then maybe some type of personality disorder. So they could end up with 15 different diagnoses. And, and
Yeah.
the thing about with our medication, a lot of times our medication is crossbred, if you ask me, in the sense to where it not only works for blood pressure, but it works for depression too. So, but yes, I have seen that. Now, the position I was in before I came to NAMI, I was the director of some mental health centers, and we actually signed a contract with one of our local um, uh, housing groups that are designed specifically for IDD. So they would bring the clients over to see my nurse practitioner who loved treating that group. So she had such good knowledge of combining mental health and IDD together. And that's really what it takes. But so we were able to see, some different types of meds that she would give. But she was very uh, fanatical about wanting to make sure that she not only treated IDD but the mental health with it. So
Yeah, and so I assume that with the work that you've been doing, that you have encountered and probably spend quite a bit of time in your training on trauma, because
absolutely.
it's sort of like, I did work in this field for 20 years before I think we really started recognizing
Mhm.
the tremendous impact. I mean, PTSD's been around forever, or not forever, but for a long time.
Right.
It's been emphasized, but we didn't really think about how that might apply, particularly to people with intellectual and developmental disabilities, because we found now that over 70% of people with intellectual and developmental disabilities have had adverse childhood experiences, and not the least of which is just having IDD, because oftentimes you're invalidated, you're not really made a part of things
Hmm.
as a person with IDD. And so I'm wondering to what extent you talk about trauma in your training and how important you see that as in understanding the person that you're dealing with when you get
Well,
into
and
it.
again, trauma is a topic that we always include in our CIT trainings, because the first responders need to understand how important trauma is and how it really does affect them. And I actually thought that percentage would be a little higher, Dr. Davis.
It probably is, really, when you get right down to it. That was published in a study by Nora Baladarian back in 2013.
Okay.
Just a lot of those data were coming out, but it certainly is very prevalent. I mean, so when you look at something like PTSD and having had a negative experience that results in your having flashbacks and other types of responses to that trauma you've experienced. It's a smaller number than that of people who actually have PTSD, but
Uh-huh.
the invalidating experience is more broad, and that's why, as a basis for sort of responses that are very similar to someone with PTSD, you will see in people with IDD because of that experience that they've had. So it's clearly very big within the IDD population. And so as you're talking about trauma, what kinds of things are important with that as people are thinking about the work that they do, just generally?
Well, one thing that when I'm teaching is to understand exactly what trauma is, but then also understand how detrimental trauma can be. Research has shown that one traumatic event does change, the brain activity. And so when we started really examining uh, children and adults and created ACEs, because ACEs has been around for a while, but
Right.
again, a lot of this is it's almost new. And the
Yeah.
same thing in discussing trauma and how it may affect, because I'm a firm believer that through somebody's trauma, it's, everything's based on experience. And so they're going to
Right.
continue to behave based on that experience unless they have a different experience. But what I see as far as in the mental health field, we do focus on trauma a lot, and we do try to understand that. Now, how far have we gone in understanding trauma with IDD? We still got a lot of work to do.
Yeah, yeah, and it's it's one of those things. I think when I first started understanding this, and you talk about PTSD, a lot of times you think about those people with borderline personality disorder,
Right.
and I hate, this was brought up earlier in another meeting I was in, but I almost hate to bring the term borderline personality disorder up because people in the past have always looked at that as sort of like oh my gosh, well, there's nothing we can do here.
Right.
I think for me, Marshall Linehan really turned that around
Yes.
with her DBT work.
DBT.
And I think, once I started looking at a lot of the issues that I was looking at through that trauma lens, it made a huge difference in the way that I started responding to people and trying to treat people and really trying to be more respectful and more understanding of how that trauma was impacting the present moment. And so I just wonder, because so often, especially, when you're dealing with a lot of these things, a lot of stuff looks very behavioral. It looks like, oh, well, this person's just trying to get something they want or whatever. But when you step back and look at it through that trauma lens, it takes on a whole different meaning. And then your responses, everybody around that person, if they respond to that person, they respond in a different way, in a more supportive way. There's always limit setting within the context of this, but ultimately you've got to be able to provide support and help for that person in learning to be confident in themselves.
Well, absolutely, and I completely agree with that because the one thing that DBT treatment for the personality disorders like that really focuses on is dysregulation. And there's many different types. It's emotional, there's physical, there's mental, there's spiritual, so many things. And when you start talking about somebody that may be diagnosed with borderline, it's really it's instrumental in kind of understanding where they came from. And that's why the type of work that we do as a therapist with DBT in a therapy session is we do a rewrite. We basically write down, and we use mindfulness when we do all those things. I think when it comes to IDD and mental health, one thing that mental health started doing several years ago is started focusing on person-centered type of treatment.
Mm-hmm.
And that would work well with IDD as well. Because really under DBT and in that personality disorder, it's person-centered. It's very specific to
Yeah.
where the person is at. I used to, gosh, when I was trained all those many years ago, and when I started training therapists, I remember one therapist being so frustrated because if she would only do what I tell her to do, it'd be okay. Well, guess what? It's not about you. You're not the one in therapy, or maybe you should be. I don't know. But it's not about you. It's about where they're at. So you learn to meet them where they're at, which is the same concept for me in dealing with somebody who is dually diagnosed. I had a special ed teacher. She and I were talking because I usually have the special ed teachers come in through CIT trainings as well and talk about and their students and from the kiddos and perspective. And she said something to that just made so much more sense to me, and that was she said, as a first responder, you may encounter somebody who is nonverbal, but she said, don't ever forget they can still communicate.
Yeah.
And you should see the look on some of those first responders' face. It's like, oh God, I never really thought about that because we take for granted as far as being able to speak.
Yeah.
So there's ways that therapists can communicate with somebody who it may be diagnosed with IDD and verbally non-communicative. And I think, again, it just goes back to training and education.
Yeah. And, Kim, there is some training out there, and there's a lot of reference materials. I mentioned NAD a little while ago, but folks are interested in finding more information. They can go to thenad, THENADD.org. There are tons of resources on there for clinicians who may want to learn more about serving with people with IDD. One of the things I will mention is that our NAD conference, the National NAD Conference, we always have our Tennessee chapter NAD conference here in Tennessee, but this year the national conference is going to be in Tennessee. And I would encourage everybody, literally everybody, to attend our national conference here in Nashville this year, December 13th through 16th, because I think people will learn a lot about all the things we're talking about today, but also come in contact with a lot of resources that they can use to help them future plan and work with things. And I know NAMI does a lot of this work too. And you have an annual conference in Tennessee, correct? Yeah.
Yeah,
so
absolutely.
There are opportunities for people to access the education. Well, it seems like to me what we got to do a little bit is try to motivate people to access that training and to prepare themselves for this type of work.
No, absolutely. And I want to start bringing it more to the forefront from a mental health perspective, and just to mental health folks in general. I would love, one thing that NAMI does is we have a state conference every September. And this year it's September 21st and 22nd, which is a Thursday and Friday. And I would love to have somebody to be able to come and speak about IDD. To the NAMI family members, to first responders, to mental health folks, everybody that comes to this conference, just to talk about how to coordinate mental health and IDD. Because a lot of our families that we deal with, they've got children who are diagnosed. They've got their adult loved ones who have been diagnosed with IDD and mental health. And
we've already on the calendars. We're going to have somebody. We will have somebody who can talk to you about.
And I think that would be great, because I think it's a topic that needs to be discussed at many more different venues than just one designed for IDD.
Yeah.
Because it affects everybody. And I want therapists to know how to deal with someone, how to accurately diagnose somebody.
Yeah.
That's where those long list of 12 diagnoses come from.
Yes. And of course, it also is just that we don't ever screen any of those out. We just add them to the list. That's part of the problem.
That's exactly
right. I
I
was talking about resources through NAD. We have the Diagnostic Manual Intellectual Disability, which is a great tool for clinicians to use to be able to differentiate, okay, here may be what schizophrenia looks like for a person with ID, or for a typical person. Here's what it looks like for a person in the mild to moderate range of intellectual disability, and here's what it looks like for a person in the severe to profound range of intellectual disability. And give some tips on how to sort those things out and to understand the underlying mental illness that someone may have in those circumstances. So that's just another great resource that comes from the National Association for Dual Diagnosis. Babs, we've had some comments I've noticed in the chat box. Do you want to talk about those a little bit and just tell us?
Yeah, I wanted to see if Mickey wanted to come on and ask his question himself.
Yeah,
I'll ask him. Perfect, thanks.
Mickey? Mickey Tona?
I turned on the phone. Is that working?
I thought I was going to find you at a loss for words, which I've never seen.
I am listening. Hold on a second. Let me figure out this camera. There we go. In short, my question is that in all the presentations I've been in that discuss this, because I'm in the field of IDD, we're always talking about bringing in more mental health services, supports, techniques, things like that, to help the folks with IDD. But I'm also looking at the progress that's disciplines like behavior analysis or behavioral interventions, as you two were talking about DBT and all that, which is about, actually doing it. And I was just wondering about flipping the question and saying, maybe the answer is in why mental health services haven't adopted more of the progressive, helpful, beneficial things that IDD has done. So, I, in some ways, we're kind of tapping the wrong well, or we could tap both of them. And
Right.
I just, my question is, so what do you think, what kinds of changes might come about if some of the services and supports that are in IDD, like person-centeredness,
Hmm.
were more wholly adopted by the mental health um, field? So that's it.
Well, I think you're right on with it because you're right. It's almost like that. I think you do need to tap both wells because I
Yeah,
think it goes both ways. I really do. And again, that's where I think bridging that gap between IDD and mental health. It's just like what we had to do. We had to create this bridge between law enforcement and mental health
yeah.
because we never
Same
got
in
along.
IDD. Yeah,
And exactly. Same
yeah.
thing with IDD and mental health.
Okay.
And so one way that we do that is through CIT. But
Hmm.
I believe in providing education and training and asking the experts.
Yeah,
Because mental health always touts that wherever the experts in this, well, you know what? There's experts in IDD. And finding out from you all what works and what doesn't, and what suggestions, what things would make it easier for somebody that may be dually diagnosed to come into that mental health setting.
and in one way, in part of the conversation, it would be if the same caliber, or if not better, or similar,
Hmm.
behavioral health services and supports, were, if it was more familiar, it's like
That's right.
we know how we're going to be treated. And then if you look at that so far as in training professionals and DSPs and whatnot to take more, a positive behavioral support approach, um, we may have a more massive benefit across everybody.
Hmm.
Anyway,
Yeah.
that was it. Just something
No,
to
I,
ponder.
I I agree with you completely. That's
Well,
why
thank you.
I think being involved in our conference in September is going to be just an excellent starting point of bringing together all these different groups. And uh,
Yeah,
and I would love to be a part of continued discussion on what can we provide to mental health providers to increase their understanding of IDD.
Yeah.
yeah,
And behavioral based services and support, just from my perspective,
That's right.
because that is one thing that was directly infused into IDD. With Bruce and I remember, having to, you know, answer the court reviewers and all that. Um, and I've not seen an equal assertion for a particular brand or field or discipline of services for folks with, it's sad. It's really sad. Um,
Well, and you all may know better than I, but when you really think about it, we've had so many, like the big topic right now is mental health and law enforcement,
yeah,
their own officer wellness. Well,
yeah,
why isn't there a discipline of mental health with an IDD?
exactly. Yeah,
And there really never has been. It's like I
yeah,
said, going back and doing this for as many years as I had, there has just never been training
yeah,
on it.
yeah.
yeah,
It's people who have gotten their training through catch as catch can,
That's
basically. That's
exactly right.
the unfortunate aspect of it. But the important thing, I don't want to be
thank
lost
you.
in this
I'm going to mute
discussion
myself.
is uh, the important thing I want to say here is that it's not one or the other. I think that's the problem we face so often in this, is that it's not IDD or mental health. It's not behavioral or mental health. And so, going back through history, we hear a lot of times, well, it's all due to the ID. It's all due to behavior. So often it's not due to just those things, although those things do
Right.
have their role in everything. The point is making it an interdisciplinary process where everybody's making their contribution. Kim, I was remembering back to when I first started in this field, someone had a great analogy to this and said that if there were 5 or 6 people who were blindfolded and they touched a different part of an elephant, they would describe the concerns of what the elephant was like in a lot of different ways that weren't connected with one another. But the elephant is a whole object. I mean, it's a whole organism. And so you have to be able to connect the dots between these folks in order to be able to understand a full description of what an elephant is. And, you know, I don't want to push the analogy too much, but that's when we're trying to understand a person with IDD, it's sort of the same thing. You've got occupational therapists who may see the person with IDD in a particular way. You have psychotherapists who may see them in a little bit more of a mental health, from a mental health perspective. And you have behavior analysts who are looking at the reinforcers, you know, that may be sort of contributing to this. So everybody has a piece of the puzzle, but nobody has the whole puzzle. You know, I don't know if you agree with that or not, but that's,
I do completely, because even like what Mickey was talking about, you know, again, we've operated so much in silos. Because you remember being in this field for as long as you all have, you remember where if somebody was diagnosed with bipolar disorder, but then they also had an alcohol disorder, you'd send them to treatment just for alcohol, because the treatment for alcohol, they didn't want mental health meds because that went against what their philosophy was. And so you treated just bits and pieces. There never was a holistic approach until people started realizing that co-occurring exists. And in order for deal with the bipolar, I need to deal with the alcohol as well. And so to me, that's what it is right now. Again, there was no bridge between mental health. Mental health was, or law enforcement was so distrustful of mental health. They thought all we did was hug trees, hold hands, and sing Kumbaya, you know. And the reality is they've come to the realization that that's not what we do. That's not who we are. But it's because we're educating them about mental health. It's the same thing with mental health and IDD. Well, if they're IDD, they got to go to this program. But what about their mental health? Well, when they finish that program, then they can go to a mental health program. And it's not worked. So it's not either mental health or, like you were saying, it really is mental health and IDD and.
You brought up a key word too in what you were just talking about, which is the word trust. Because when we're working across systems, trust is often hard to come by. You know, we all have different aims, different things we're trying to accomplish, maybe with the department we're in or with the organization we're with, and so on.
Right.
I don't know. Have you seen trust to be an important part of these interdepartmental, interorganizational relationships that we develop? Why don't you speak to that just for a moment?
Absolutely. And again, I'm using, when I first started with CIT about 12 years ago, honestly, the perception of law enforcement of mental health was what I had described a few minutes ago, and that we were going to diagnose them, and that's all we do. And there was so much mistrust. And I remember working with one county in particular, helping them set up, and they started saying, well, we don't trust mental health here because they did this and this and this, and they said they can't do that. And all it took was bringing mental health and law enforcement in and letting them each ask questions of each other.
Yeah.
To understand. And then our next meeting, law enforcement spoke up and said, well, you know, once we talked to mental health and they said that we got a call on somebody during the day and we thought that they needed to go, we could take them over to the mental health center. And the chief of police spoke up and he said, that's exactly what my officer did. And it worked beautifully. But they would have never understood that they had never not come together.
Yeah.
And to me, that's the trust aspect of it.
Yeah. I think about all the time, trust as it relates to some of the problems we face. Because that, you know, on the legitimate side of hospitals often not accepting people with IDD, there's a fear on their part about what this is going to mean. And, you know, is this person going to be with me forever? You know,
Exactly.
and, you know, on the other side of it, I think the IDD system has to develop trust that that's not what we're looking for.
Yeah.
You know, that what we're looking for is somebody to help get this person stabilized so that we can help them get back to their community setting and be successful. And, you know, that's a trust that's not built overnight, but it's one that we have to continually work on and try to avoid circumstances where that trust gets violated.
Right.
You know, we can all run into circumstances where things don't work out the way that they're planned, but we have to be upfront and own that.
Well,
Nikki, I'm sorry, go ahead.
no, I was just going to say, and you know, what I was saying earlier about our experiences, that's where our beliefs are based on and our perception. So there may have been one incident that occurred with the state hospital and a patient that's IDD, and now all of a sudden, oh no, they'll just leave them here. Because I've heard that working in the mental health field. No, we don't want to keep somebody or take somebody who may have IDD as well because we're not equipped to handle it. And what if they don't come get them? Then what are we supposed to do with them? But there may have been one incident, but now the perception is, no, let's don't take them because they don't come get their folks. Same thing with law enforcement. My client can have a horrible interaction with one officer and all of a sudden every officer's bad. And so, and it does, it just takes some time. Yeah, it does take time, but we've got to continually work at building trust and helping people know that we're not here to create problems. We're here to try to solve them. That's right.
Nikki, you came back on. I know you came back on camera-wise. I don't know if you intended to ask another question or not. Oh, okay. Is there anything else in the chat box, Babs?
There is, and Dr. Davis, you're familiar with this, but the training for police deputies and EMTs is an issue that the state's Autism Council is very interested in. So that was a comment from Janet Sheps. And I know it's something we've been talking about a lot in those committee meetings.
So the interaction in training law enforcement, because it's like I said, we even have just a separate presentation on autism. Not only do we have a presentation on IDD, but also autism in general, because that seems to be a lot of folks that first responders come in contact with. And just being able to look for certain things, being able to understand. And again, that's where that communication, they're nonverbal, but they can still communicate. So in our trainings, we'll have special ed teachers that will come and talk about and dealing with kids. We'll have parents of adult children with autism or their minor children with autism. Furthermore, we've got one, he's actually a police officer who has two boys, both diagnosed with autism. He comes and talks about it not only from law enforcement perspective and what to deal, but also from a father's perspective. So it's very powerful. And we just find that is so beneficial. And typically the officers or the students in the class will talk about it later on in the week. I did not know that about law. I did not know that about autism. I did not know that what stemming meant. Yeah. You know, something as simple for us who have been around that, but they had no clue what that was. Right. So that's really interesting. I appreciate that comment, but I promise that's exactly what we're trying to do, is to educate them more.
We do have one more question. What are some common deficits that you have seen among behavioral health clinicians treating IDD?
To me, the most common deficit is just the lack of understanding and knowing what it is. And knowing what, just as autism and folks with that diagnosis, there are certain elements and signs to look for there would be maybe not even understanding that there could be in relation to somebody else with an IDD diagnosis. So it really is the lack, and I know I've said it over and over, but to me, it's just the gut of it, and that is the lack of training in dealing with somebody with IDD, and that's where
Yeah.
clinicians get stuck.
Yeah, such a big part of it is communication
Yeah,
and figuring out how to communicate, sometimes on a little bit different level or a different way that helps people understand things more effectively, what you're trying to
Right.
get across to them. You have to be creative, when you're doing this work. It's not all just lined out. You can't just follow a protocol that somebody put together to try to do it. You have to work with that and be creative. And I think over time there will be more and more
yeah,
technology associated with this, but technology is only part of it. You really still have to be creative in the moment, and to think about those things that you need to do. There is training out there that helps
yes,
people think through things. There is one Relias training that is specifically for clinicians who work, say, in a mental health center who want to learn more about serving this population, that they get that training through that. And I actually, now that I've said it, I'm going to have to put that resource out there for people. But there may be some cost in getting it, but it's a step in that direction to help you get stronger and better with that.
Well, and I agree with that. Yeah, I agree with that because, as a licensed therapist myself, whomever I'm going to be working with, it is my responsibility to learn as much as I can about whatever disorder that may be, whether it's somebody with autism, another form of IDD, somebody that is experiencing gender issues, because they don't teach you about that either, and provide
Yeah.
training on that. And so
Well,
ethically, it's my responsibility
yeah.
as a therapist. And I don't know that therapists know a lot about the resources and what to look for.
Yeah, there's so much. There's a lot out there we need to know, and we need to know better. We even know now. So, Babs, any other questions in the chat box or comments that you want to
Nope,
address?
that's it.
Well, Kim, I appreciate so much you taking an hour out of your time to talk to me today and to talk to our network. You're part of our network. I hope you know that. This may be your third time maybe presenting for us, or at least your second.
I think this is the second time.
Okay. Because I want to encourage you, if you get 5 times, we give you a figurative green jacket for that. So,
great.
I want you to keep coming back and talk to us because it's great to have these conversations with you. And, really, it underscores the partnership that we've had with you over these last years. That it's really been very good and very effective and helpful to us, and I hope helpful to you as well.
Oh, absolutely. And it's like I said, that's why I enjoy this format of we just talking and communicating, because there are things that I learn every time from you all, because IDD is not my specialty. But I can bring some knowledge of mental health to it. And I just really think that this format works really well, because that goes back to the communication, which is what we need between all of us.
I tell you what, we got 2 minutes left. Joan Jenkins has her hand up, and I think maybe wants to come on and ask a question. So let's let her do that.
Okay.
Thanks, Bruce. Hi, Kim. How are you?
Hi, I'm good. How are you?
I'm doing fine. I just wanted to say that, well, a couple quick things. There are so many pieces to this, and we all try to tackle different pieces of it when we have an opportunity to do so, to move that needle. And I just wanted to let everyone know that in our meetings for the behavioral health advisory boards in October, Kim is actually going to be one of our presenters, and she's going to be talking about CIT across Tennessee. And then we're also going to have a presentation on conflict management and de-escalation, because that's a part of this. And it just kind of, here again, that bridge, trying to get people to better understand and how they can interact and how they can help move things forward. Another part of it is that one of our fantastic board members recommended that Blue Care establishes a directory of providers who have compassion and understanding about IDD and want to actually treat individuals. And so we recognize there are a lot of barriers there, but we are still proceeding and tackling those things. Part of it, Blue Care is involved in educating young professionals, future professionals on IDD so that they can have a better understanding while they're in school and then come out and want to be able to treat individuals with IDD. So we're involved in that part. Another part of it is, and Bruce, you know that we've been working a long time as far as trying to get family support specialists who are certified because they might have loved ones who only have an exclusive diagnosis of being on the autism spectrum to be able to get certification as a family support specialist. So I participate in the FSS, the Family Support Specialist Steering Committee and the Advisory Council. And as a result of something that happened years ago and recognizing that if your individual that you love and care for is exclusively or has an exclusive diagnosis of being on the autism spectrum, you were not able to get that certification as a family support specialist. So we've been bridging the gap between IDD and the Tennessee Department of Mental Health and Substance Abuse Services so that now we're finally, after all these years, seeing that needle moving forward, that an official recommendation has been made and the commissioner is looking at it so that people can get that certification if they choose to do so. Because if they want that certification, they should not have to have their child or loved one have another diagnosis in order for them to get that certification. It just doesn't make any sense. And so I continue to be that voice, and we're moving that, and we're looking forward to being able to report back at some time in the near future that we actually have accomplished that goal.
You've been out there for quite a while, Joan. I'm so glad that you're achieving some success there, and I do hope you will kind of keep us posted on that. And
I certainly will.
Yeah. Tim, I just want to thank you so much for being a part of this today and having this discussion with us. This was great, and I hope that, as I said before, you will come back with us.
Absolutely.
We do this every Tuesday.
I want that green jacket.
Yeah, you got to get that green jacket. That thing's real important. So okay. Well, I appreciate all of our network. We will be back here again next week at 12:30 Central Time. So please join us for the Clinical Consultation Network. We'll see you then.
Thank you all. Bye-bye.